Usually when there's a hindrance of development and progression of research, not just overall research, but actually, beneficial and productive research, it usually comes at the fault of there being limited screening opportunities, limited diagnoses, just no advancements on that side, sort of like a chicken or the egg, which came first
Yeah.
situation of why don't we have enough patients to observe and assess for different outcomes,
Yeah.
it's different agents. So could we talk a bit more about that, about the real-time actual, patient screening measures, and how much a statement like what was put out by AHA and ITSH really hooks onto that?
Well, the patient screening in terms of the biomarkers, is that what you meant primarily? Well, I'll tell you that if we have a suspicious patients or patients coming with a classic complaint or suspicion for either a DVT or a PE, we've all used to the good old D-dimer. And to start with, I would say that even that is not utilized to the best of its capacity. I will just not digress, but widen the discussion for a few moments by saying that the D-dimer level really should be utilized in general medical office, or whoever the physician who took on himself or herself to follow a DVT or a PE patient seriously should do every 2 to 3 months. Ideally, the decision making about the length of the anticoagulation can be helped extremely by understanding the D-dimer trends and whether the moment of discontinuation anticoagulation should be appropriate by measuring very low or normalized D-dimer. We know that folks who had DVT, for instance, and have finished their 3 months for, let's say, provoked DVT, do have still elevated D-dimer at the time of 3 months of completeness. And although symptoms may be gone, interestingly, these patients have a significantly higher recurrence rate of the DVT on the ipsilateral side. So although this is something well used and well described in fairly cheap tests and screening tests, it's not utilized to the full capacity. There's a number of other newer screening tests that we can do. There is a soluble p-selectin with factor 8. There may be an extracellular DNA intercellular adhesion molecule 1, and some studies have been published on both animal product and in vitro model, and they're showing a potential benefit. However, we're talking about significant expense, and having a lab test that's fairly not well validated compared to the D-dimer and to a prognosis. So those would require significant investment into a study that would selectively study each and every one of these and compare them to the reliable D-dimer that we have so far. But these are certainly some additional screening tests that should be done from a blood sample that can be used for proper triage for the VTE and potentially prognose the recurrence rate.
Wow. Well, that's excellent, and it's very fascinating to hear that that maybe, I guess, the means by which we can do it. It sounds tangibly, as you're speaking about it, something that could be changing sooner than the therapeutic options at the very least. That's something.
Yes.
Yeah.
Yes.
Yeah.
And the whole medicine actually is going towards this individualized medicine trend, and I would say the VTE. And I think one of the reasons the whole research and attempts so far have not yielded as much as we were hoping is that it is so multifactorial. You truly have to take into account specifics that may be genetic, that may be environmental, that may be thrombophilias that we may be missing, or thrombophilias that are not discovered yet. I just want to remind you that out of those that present with a non-provoked DVT or pulmonary embolism, about 50% of them will not have a classic thrombophilia. And we would never really quite understand with current level of the markers, why would they suddenly clot without any obvious injury or trauma? And they have a phenomenal rate of recurrence. So there is a whole, undercovered, probably molecular level marker array that we have not even scratched upon, and they require some research. And I wonder if a combination of other factors may be added to a tendency to clot other than just the genetic tendency.